You are now listening to MedEd Talks Primary Care, a Vindico Medical Education production. The following podcast series is titled Expert Weigh-In Podcast Series. To earn CME credit, log into mededtalks.com and search Expert Weigh-In, or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and the learning objectives. Now, here's your host, Dr. Robert Kushner.
Hello, I'm Dr. Robert Kushner, professor in the departments of medicine and medical education and former director of the Center for Lifestyle Medicine at Northwestern University Feinberg School of Medicine in Chicago, Illinois. I'll be your host for this exciting new podcast series titled Expert Weigh-In. In these podcasts, I'll be interviewing physician experts on various topics in obesity management. In this episode, new definitions for obesity, preclinical obesity, and clinical obesity, I'll be speaking to Dr. Tim Garvey. Dr. Garvey is a professor and chair in the Department of Nutrition Sciences and director of the Diabetes Research and Training Center at the University of Alabama. Welcome, Dr. Garvey.
Thank you, Bob. It's a pleasure to be here and to speak with your podcast audience.
Tim, I've been looking forward to this podcast. The premise of the episode is the recommendations from the Lancet Commission on the definition and diagnostic criteria of clinical obesity that was published in January 2025. The recommendations have been embraced by some and frankly opposed by others. Now, in full disclosure, you and I were commissioners on the global initiative. The commission introduced two new terms to the world, preclinical obesity and clinical obesity. So to set the stage for the rest of our conversation, Tim, why did the commission feel it was important to readdress how we define and diagnose obesity? Why can't we just use BMI alone to diagnose obesity, which is what clinicians currently use when they code for obesity in the office? And finally, what distinguishes the two new terms of preclinical and clinical obesity?
Yeah, Bob, these are questions that the commissioners struggled with and eventually came out with the recommendations in the report from January. You know, I think it boiled down to the fact that there are patients that have excess adiposity that are otherwise pretty healthy. I mean, they get around, they're happy, they're productive, they exercise, they don't experience some of the complications that we associate with obesity. But we know that because they have excess adiposity, they're at risk of developing complications. So the question was do these people really have a disease if they don't have structural and functional dysfunction of organs that create symptoms and impair quality of life in a sense, or is it just a risk factor? And then we decided to call that preclinical obesity. I don't think this is something really new. I mean, I think as clinicians, we've always recognized that we have patients with excess adiposity that do pretty well. In many guidelines, these are just classified as patients with obesity, but without complications. And there, we know we're in more of a preventative mode of treatment. We want to prevent the emergence of complications. But clinical obesity then is when we do see structural and functional changes in organs that give rise to symptoms. And I think this was an advance, really. It really taught us that obesity is really a disease because there are complications that are integrally related to the state of excess adiposity and really not too much else. For example, hepatic steatosis, NAFLD or MAFLD, this combination of high glucose levels, high triglycerides, low HDL, kind of a metabolic syndrome type state would be considered integral to the state of obesity, increased adiposity. There's an obesity glomerulopathy that was defined, and other things like stress incontinence, lymphedema, hypoventilation. All of these things are integral to obesity and really part of that disease state. And when a patient has clinical obesity, we really, I think, kept it we're now in a treatment mode, a tertiary prevention mode, where we have to treat these complications, prevent further disease deterioration, and get sufficient weight loss to achieve those clinical goals.
Yeah, I don't think these terms have really bubbled down or trickled down to patients yet, but I find very few patients who want to be given a new disease when they see the clinician. And I think it really resonates a lot of patients. They get the idea that they have excess body weight or they're overweight and have a weight problem. And it's a way to talk to them that it's a risk factor. It may lead to obesity, which is about the only time I ever use the word obesity in my clinic is when I'm talking in medical terms. So I think it really does separate out a lot of people who don't view themselves as having a disease.
You're right. I mean, it's our job, though, I think, to explain to them the risk or potential risk to their health that excess adiposity entails. We don't have to tell them they have a disease, but they have to understand what the potential sequelae are and implications are of excess adiposity. If they're doing well and they're exercising and they're normal glycemic and their lipids look good and they feel good and they're getting around and productive, I think, we don't have to tell them they have a disease, or we don't even have to tell them they have preclinical obesity, So you're right about that. And there's lay groups that advocate for this too. But I tell you, Bob, how common is this preclinical obesity? I think that's an open question that hasn't been resolved yet. And it's going to be a function of how well we've evaluated the patients for complications, and that'll determine whether they have preclinical obesity or not and how common that is.
Yeah. Let me go back to this distinguishing between preclinical and clinical obesity. What is going on biologically, metabolically, mechanically that sets the stage for that transition from preclinical obesity to clinical obesity?
Well, I think we need more data there, but we know obesity is a polygenic disorder. I mean, you have to inherit large subsets of genes. At-risk alleles, susceptibility genes, interacting with environment to develop excess adiposity. And then what determines who gets complications, what complications they get, and how severe those complications are? Well, we know it's going to involve perhaps overlapping but different subsets of genes interacting with different environmental cues. And this is going to determine, somebody could have a BMI of 35 and be otherwise healthy or have a whole host of metabolic and cardiovascular and biomechanical complications. And it's just, it's just their genetic predisposition and their environmental interactions that determine that and how severe those complications will be. But we know the state of excess adiposity is playing into that. And so, but in terms of individual complications, we could identify maybe specific susceptibility genes in some cases, like MASH genes, or and then environmental cues. If we have difficulty with ventilation and somebody smokes and has COPD, that's another environmental cue that's going to exacerbate that. So it just depends on the complication and on the patient.
Yeah, I think a big part of it, I think, Tim, you'll agree, is the development of inflammation, adipokines, insulin resistance, right, leading to that whole metabolic cascade as far as the metabolic complications, right?
Yeah, that's very true. That's in terms of the cardiometabolic nexus of diseases that constitute obesity complications. You're right. It begins with insulin resistance and inflammation and fat, and this is also associated with endothelial dysfunction, an ectopic collection of adipose tissue and muscle cells and liver cells, and and it's basically the insulin resistant state, which is subclinical over much of the lifetime, but then it does give rise to clinical signs that we all pick up. Prediabetes, metabolic syndrome, hepatic steatosis, prehypertension, dyslipidemia. When we identify those in patients, we know they're insulin resistant, we know they have cardiometabolic disease, and we know they're at risk of progressing to the end stage manifestations of of cardiometabolic disease, which is cardiovascular disease, coronary artery disease, congestive heart failure, MASH, overt diabetes, and hypertension. And then a lot of these factors conspire to worsen kidney function. So CKD really becomes part of this nexus of disease. And of course, obesity exacerbates insulin resistance and impels this whole disease progression forward. And we know that treating obesity can help prevent and treat many of these cardiometabolic disease manifestations.
Yeah, so a clinician, of course, can't pick up on a lot of these biological and metabolic abnormalities that are going on in the inside the body. And I think one of the most significant contributions of the commission, you and I agree, this is a work in progress, right? It's a recommendations. It's a think piece that you and I are talking about, not a guideline or standard of care. But I think one of the significant contributions is for the first time, we painstakingly tried to connect the dots between abnormal, dysfunctional fat and signs and symptoms or biomarkers or quality of life. So a clinician can actually identify, does the excess body fat causing harm for the person sitting in front of them? And you mentioned some of those already. Do you want to talk a little bit more about that?
This is my opinion. I don't think we need fancy biomarkers like, insulin levels or, various cytokines. When we detect, high triglycerides, low HDL, when we detect, abnormal glucose to high fasting glucose levels, when we detect higher blood pressures, if we discover that a person has increased LFTs, a liver function test, and determine that that's associated with increased fat in the liver, we do that. We can do that. We've got that. And that really tells us a lot of information about how obesity, excess adiposity is affecting cardiometabolic disease health. And, we need to really be, preventive and therapeutic in those patients and get sufficient weight loss to achieve our clinical goals there.
Mm-hmm. Tim, there's another concept I want to talk to you about that the commission actually did not address. And sometimes I think there's confusion among readers of the commission, and that is we did not assess obesity risk staging, something I know you're very, very comfortable with and knowledgeable about and developed your own staging system. I think most clinicians understand risk assessment staging since it's routinely used in CKD, cancer, and so forth. But can you talk about the difference between staging, how we do use that in obesity, versus what you and I are talking about, which is preclinical obesity or clinical obesity?
Yeah, I think it's interrelated. It comes down to what I call complication-centric care, which is really all obesity treatment guidelines harmonized around this issue that we're treating a chronic disease. And like other chronic diseases, we want to prevent and treat the complications of the disease because those are what really impair quality of life and confer morbidity and mortality. So yes, we do want to engineer weight loss. We want that for our patients. But why do we want that? We want to do that to improve their quality of life and to prevent and treat complications. So those are really become the endpoints of therapy and the basis for disease staging. I think the idea here from the commission that the differentiation between preclinical obesity and clinical obesity and in staging paradigms is to identify patients who are sicker, who are at highest risk, where treatment is going to have the most favorable a benefit to risk ratio and are going to have greater cost effectiveness for that matter, where we can really help people and make a bigger impact on their quality of life. So, I guess the feeling of the commission was that preclinical obesity versus clinical obesity is that clinical obesity are the patients we could most benefit from a health perspective through weight loss therapy. The ACE guidelines that I participated in had very simple, clinically intuitive staging, which is, one stage, or stage 0 is obesity without complications, right? Very analogous to preclinical obesity. And then if there were mild to moderate complications, That would be stage 1, and severe complications stage 2. But once you have complications, whether it's stage 1 or 2, or whether you have a BMI of 38 or 28, that tells you that that degree of adiposity is impairing the health of the patient, and we really need to treat the patient accordingly. There are other more elaborate staging mechanisms that incorporate, emotional, psychological, as well as functional and clinical aspects to the disease. The Edmonton criteria that you've been associated with, Bob, and I think those are valuable too. But the idea is just to really try to identify which patients are sickest, which patients have the most complications that are putting their health at risk, and to treat those patients more aggressively.
Yeah, I'm so glad you clarified that. And so that they're not opposed to each other. They give you different types of information. If you have clinical obesity, then you may wish to stage that individual for aggressiveness and intensification of therapy. So they can be worked together.
Well, I think the controversial aspect to the Lancet Commission was preclinical obesity. Was this a phenotype, if you will, that should be treated or not? Are we saying that these patients shouldn't be treated because they don't have complications? And I think that's a misunderstanding. I think these patients do need to be treated, and more from a preventative aspect, of course, but particularly patients at higher risk of going on to clinical obesity. I mean, we need to treat these patients too, and it doesn't mean that they don't deserve treatment, but they definitely, and they deserve follow-up as all patients with excess adiposity do.
I think you raised probably the most significant controversial point that I have seen, at least in the literature and LinkedIn and all the other social media, is I think the misunderstanding that if you have preclinical obesity, you do nothing, no allocation of resources, don't do anything until they develop clinical obesity. So I'm glad you raised that, and I agree with you completely. For me as a clinician, that's where we really want to pay attention and have that conversation with the patient to prevent the development of clinical obesity. And that can include pharmacotherapy, bariatric surgery, lifestyle management, counseling, all of those methods.
Right. What does the patient want out of therapy? And many patients do want just to lose weight. Of course, they want to feel better, they want to lose weight, and they want to look better. And so as clinicians, we want to improve their health. And so I think what I call it harmonization of the treatment goals, to try to make sure the patient understands the health implications of excess body weight and what our goals of treatment are. Yeah, we want them to feel good too. We want them to think well of themselves and to get around as well as they can. But we also want to treat and prevent any of these complications from arising. So we've got to kind of understand the patient and the healthcare professional, I think, need to come to some kind of understanding about all of that as we go forward, because, not everybody responds to any one given form of treatment. And a patient may be dissatisfied with the current therapy, but the doctor may be because of the health benefits, and vice versa. So we just have to work together with our patients, incorporate their input as we go forward. But you know what I'm talking about.
We call that shared decision-making and patient-centered care. That's what we... So, Tim, here's a question that came in from one of the listeners. I'm going to have you put your endocrinology hat on. It kind of goes a little bit off topic from what we're talking about, but there are other lipid dystrophies or other abnormal fat accumulation syndromes and diseases that we didn't really talk about in the Lancet Commission, where there's excess adipose tissue that does not respond to the traditional lifestyle modifications. A good example is lipedema, where you have this abnormal fat accumulation in different parts of the body. That's not what we're talking about today, right?
No, this is lipedema is a kind of a focal accumulation of fat. It's a hyperplasia of fat on a very regional basis, usually in the buttocks and thighs and maybe the arms. Kind of there's inflammation in those locations, and sometimes the skin has kind of an orangey kind of coloration to it. It can be painful but it's not a form of obesity. It is a form of focal collection of excess fat cells, but it's not, weight loss is not a primary modality of treatment. I guess it can improve pain in some cases and inflammation, but you're still going to have those focal accumulations there of lipedema. So yeah, you're right. We didn't talk about that, but it's not something that really responds primarily to weight loss therapy. I guess that's the reason.
Right. So I just want to clarify that for listeners that's not what we're talking about in today's podcast. You alluded earlier that we need to know the prevalence of preclinical clinical obesity. When I went on this social media tour when it was launched, you probably a lot of interviews too, being a commissioner. A good question to me was from the journalist is, well, how common from a population point of view is clinical obesity or preclinical obesity? And I said, we don't know. We didn't know. We put this position paper out, the think tank, as I call it. There are a handful of papers, one from NHANES, one from All of Us U.S. research program. From what I see, is completely different prevalence, probably different variables they looked at. And I wonder if you have some thoughts around that. What kind of further information do we need to get a handle on population levels of these two terms?
Yeah, these papers that have been published, you use like cohort studies or population-based data. And the degree of evaluation, the intensity of evaluation of these patients in these population-based studies is usually less than what we would do with the patient in our clinical offices, in our offices. And I think, substandard in terms of what we would expect in a patient-physician relationship with treating this disease. So I think they overestimate the prevalence of preclinical obesity because these patients haven't been worked up properly. We did a study in NHANES looking for metabolically healthy obesity, how common that was. Our definition was adults with excess adiposity that have no metabolic syndrome traits, okay, normal glucose and lipids and blood pressure. And that was about 16% of adults. Some of them had one or two risk factors and didn't fulfill all the criteria for metabolic syndrome. Others had metabolic syndrome, which was pretty common. So I think it's this preclinical obesity. Once we get a good evaluation of the patient, it won't be as common as we think, but it's definitely an entity that we see.
You bring up a very good point, which I didn't ask you earlier. You may want to kind of refocus that. I think a lot of folks confuse metabolically healthy obesity with preclinical obesity, that they're one and the same, and they're not, right?
No, and just because somebody's metabolically healthy doesn't mean other aspects. I mean, they could have biomechanical problems or osteoarthritis, sleep apnea. They could have, issues with the psychological overlay to their disease. And so that doesn't mean that they don't deserve therapy again or that that the state of excess adiposity is equivalent to a clean bill of health. No, it just means that at that point in time, there doesn't appear to be a risk of cardiometabolic disease complications over that of the general population.
Right. Okay. So I've mentioned several times that this is kind of a think piece. It's kind of starting the conversation, as how I often tell the journalist, this is not carved in stone. The debate begins, and we are looking, and the commissioners are looking forward, right, to more information so we can redefine what we've been talking about. One of the areas where it's not ready for prime time is ICD-9 coding. Right. We're still doing BMI, morbid obesity. And I know you've thought a lot about that with your ABCD definition of obesity. Where do you think we need to go at this point to continue the conversation and move forward?
Yeah, I think the ICD-10 coding is really, I guess we're moving into ICD-11, but it's really kind of, it's not even medically correct. I mean, if you translate the major code, it says you're fat because you eat too much. If you put it into colloquial terms. And that's just not accurate. It's more complicated than that. And it doesn't tell you, based on BMI, it doesn't tell you how the degree of adiposity is affecting your health. I said a patient with BMI of 38 can be healthier than somebody with a BMI of 28. And when you come down to complication-centric care, it really comes down to not only an anthropometric measure of excess adiposity. We need to combine that with a clinical assessment of the patient in terms of the presence and severity of complications, and put those two together. That's what we do with disease staging that we talked about earlier. And and then that establishes our treatment goals as we harmonize them with the patient. If we don't do that evaluation and build the clinical aspect into our kind of way we think about the diagnosis, we're not going to be able to engage in complication-centric care, which is why I don't like the availability of these powerful obesity medications online, these online prescriptions that patients can get without a true, an adequate medical evaluation. Without an adequate medical evaluation, you can't determine the presence and severity of complications, so you can't engage in complication-centric care. And I just think it's substandard. Our patients deserve better than that. We don't treat any other chronic disease like that. So that's not to say there's not a room for telemedicine and not room for online assistance with prescription availability, but just online prescriptions without nothing else, no evaluation. I just think we need to do better than that.
Well, I agree. There's a whole chorus of clinicians and scientists that back you up on that. It's an adiposity-based chronic disease, as you say, ABCD, or chronic relapsing illness or disease. So it's hard to think about treating that through telephone or through internet only.
Yeah, and if this diagnostic term, adiposity-based chronic disease, that is advocated by some professional societies. I mean, when you say obesity, we kind of think BMI. If you use the diagnostic term adiposity-based chronic disease, I mean, it tells you what we're treating, abnormalities in the mass, distribution, and function of adipose tissue, and why we treat it. It's a chronic disease with these complications that impair quality of life. And that engenders or entrains a complication-centric approach to care. So I just think it's like the difference between MASH and NASH. I don't know if your audience is totally familiar with all of that, but it's just a diagnostic term that's more medically meaningful and scientifically correct than just kind of obesity per se. But as long as we understand the need for both an anthropometric and a clinical assessment in diagnosing the disease, I think we're going to be okay.
Yeah. Tim, in the remaining minute or two, do you have some kind of summarize for our listeners, some takeaways from the commission and these new terms and some of the other topics we covered?
Yeah, I think one contribution I thought was valuable is, we use the term comorbidities and complications, and we use these terms kind of willy-nilly without any precise definition to them. And I think the commission did provide that. Comorbidities are two things that occur by chance alone that otherwise may not be pathophysiologically related. The obesity complications we talked about, those are things that are there due to excess adiposity and integrally involved in the pathophysiology of this disease. And then they established obesity-related diseases, which means, yes, obesity is playing a part, but there's something else that has to happen unrelated to excess adiposity to precipitate that complication or that obesity-related disease. An example would be diabetes, I believe, because you not only need the insulin resistance of obesity, but you need some impaired insulin secretion. As beta cells become tired out trying to compensate for the insulin resistance over years, and then the insulin secretory responses become submaximal, and then overt hyperglycemia is what's produced. So you need insulin resistance and impaired insulin secretion together. That would be an obesity-related disease, or some cancers related to obesity-related diseases. So I think adding precision to those terms will allow us to communicate better. I don't know if that how well that plays right in the office experience with your patient. But I just thought that was we needed that.
Yeah, I agree. That's fine tuning our vocabulary and how we think about medical problems that individuals present with. Thank you so much, Dr. Garvey, for this excellent discussion, and thank you for listening. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series.
Thank you for listening to MedEd Talks Primary Care. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Expert Weigh-In Podcast Series.